Okay, so in this video I'm going to be talking about the respiratory system, and I'm going to be mainly going piece by piece throughout the objective sets, and hopefully through my explanation I'll give a good example of the connections between these objective sets. So first I'm going to talk about a quick overview of the respiratory system and what happens as someone breathes in air. This air moves from the nasal cavity in the mouth into the pharynx. Then it moves to the larynx, then to the trachea, then to the two bronchi, and then from the bronchi inside the lungs, these bronchi passageways are going to then split into smaller bronchioles, and then it's going to keep splitting into smaller bronchioles until it reaches the alveoli. And so that's the respiratory pathway. And then there are two different types of muscles that are really important for breathing, and these are the diaphragm and the intercostals. And as these two muscles relax, there's a recoil of the elastic connective tissue in the lungs, and this causes the volume to decrease, and as the volume decreases, the pressure is going to increase. And because the pressure is going to increase and gases want to move from areas of high pressure to areas of low pressure, carbon dioxide is then going to flow out of the body to the low pressure in the environment. Okay, so moving on from the whole general overview of breathing and the respiratory pathway, I'm going to talk about different sources of resistance to airflow within the respiratory system. So first I want to talk about how the main mechanism behind the transport of gases within the respiratory system is that there's small differences in partial pressures, which can only be around like 2 millimeters of mercury, and this can cause a large diffusion of gases between, let's say, the arteries and alveoli. But for the resistance to airflow, I'm going to draw a graph real quick. So here on this graph, x-axis is going to be throughout the respiratory pathway. So this is like a bronchiole, and then it's going to be splitting into the different smaller bronchial tubes until it reaches the alveoli. So it's basically the x-axis is the length, or how far the air is throughout the respiratory tract. And then the y-axis is going to be the resistance for airflow. So this is how the curve goes. And in the beginning, because these bronchi tubes are so large, they have such a large diameter, the air resistance is not that great comparative to at this point, whenever there's a medium-sized bronchial tube. And because this medium-sized bronchial tube isn't as large as the larger bronchus tubes, there's a larger resistance to airflow. However, we know that these bronchial tubes here have smaller diameter than the bronchial tube here. But because there are so many of these small bronchial tubes, the resistance to airflow is kind of negated. Well, the size of the bronchiole is kind of negated in terms of the resistance for that bronchiole, because there are so many of these small bronchial tubes, and because of the large magnitude of bronchial tubes within the lungs, there's a fairly low resistance for air moving throughout these small bronchioles. So moving on from the types of resistance of airflow in the respiratory system, I'm going to talk about the 4 different types of pulmonary volumes and pulmonary capacities, with the first pulmonary volume being the tidal volume. And the tidal volume is the volume of air inspired or expired during a normal inspiration or expiration. And the inspiratory reserve volume is the amount of air inspired forcefully after inspiration of normal tidal volume. And the expiratory reserve volume is the amount of air forcefully expired after expiration of normal tidal volume. And the fourth pulmonary volume is residual volume, which is the volume of the air remaining in the respiratory passageways and the lungs after the most forceful expiration. And then so those are the 4 different types of pulmonary volumes. Now I'm going to talk about the 4 different types of pulmonary capacities, with the first being the inspiratory capacity. And this inspiratory capacity is the tidal volume plus the inspiratory reserve volume. The second pulmonary capacity is vital capacity. This is the sum of the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume, and it's basically the total amount of air that you can use. And the third pulmonary capacity is functional residual capacity, and this is the expiratory reserve volume plus the residual volume. And the last pulmonary capacity is the total lung capacity. This is the sum of the inspiratory and expiratory reserve volumes plus the tidal volume and the residual volume. So, moving on from the pulmonary capacities as well as the pulmonary volumes, I'm going to talk about the alveolar dead space. And dead space is basically the volume of air inhaled that does not take part in gas exchange. And this can be caused by two reasons. One being that the air just basically remains in the conducting airway, so it might not necessarily pass from the bronchiole to the alveoli. And the second reason could be that if this gas does pass into the alveoli is poorly perfused, so there's not much gas exchange in this particular alveoli. And while this dead space does kind of seem like wasted air, there are a few different reasons that this dead space is useful for ventilation. And so there are four different reasons, with the first being that CO2 is retained because of this dead space, and the CO2 is important for the bicarbonate buffer system, which allows the maintaining of homeostasis in the pH of blood. And then the second reason that alveolar dead space is important is that inspired air is brought to body temperature, and this can increase the affinity of hemoglobin for oxygen, which can improve the oxygen uptake. And the last two reasons why the alveolar dead space is important for respiration relates to mucus inside of the respiratory tract. But the first being that the particulate matter is trapped on the mucus that lines the conducting passageways, which allows for the removal by mucociliary transport. So that's basically like particulate which is trapped in the mucus is removed from the lungs by the motion of cilia. And the last reason why this alveolar dead space is important is that inspired air is humidified, and this improves the quality of airway mucus. So moving on from this alveolar dead space, I want to talk about the diffusion of carbon dioxide and oxygen and how it is transported between the arteries and the alveoli. So I'm going to draw this first. So for my drawing, this is an alveoli and this is an artery. So before this diffusion occurs, the partial pressure of oxygen in alveoli is very high. It's 104 millimeters mercury, and this is just because of respiration as we breathe in oxygen. However, the carbon dioxide partial pressure is lower, as it's only 40 millimeters mercury. However, in the blood, the partial pressure of carbon dioxide is 45 millimeters mercury, which is greater than that in the alveoli, and the partial pressure of oxygen is only 40 millimeters mercury. And because of this high pressure, the difference between high pressure and low pressure, or the partial pressures, this causes the movement of oxygen from an area of high pressure, being the alveoli, to an area of low pressure, being the arteriole, and the movement of carbon dioxide from an area of high pressure, which is the artery, into an area of low pressure, which is the arteriole. And so that's what causes oxygen and carbon dioxide to move between the arterioles and the alveoli. And going more in depth into oxygen transport, oxygen is going to be moved on red blood cells while binded to hemoglobin. And hemoglobin has 4 oxygen molecules to 1 hemoglobin molecule. And whenever there's an area of low oxygen partial pressure, this hemoglobin will unload the 4 oxygen molecules that it's binded to. And I'm going to draw this quick graph on oxygen content versus partial pressure of oxygen in terms of the hemoglobin binding. So you can see as the partial pressure of oxygen increases, the amount of oxygen binding to hemoglobin increases as well. So that's kind of picturing the relationship between the two. So now I want to talk about carbon dioxide transport. And 7 to 10% of carbon dioxide is dissolved in plasma. Over 20% is chemically bound to hemoglobin. And then 70% of this carbon dioxide is transported as a bicarbonate ion in plasma, which is caused by the carbonic acid dissociating to hydrogen ions and bicarbonate ions.